A very good evening to all of you from WINCARS. WINCARS, we know, is Women in Cardiology and Related Sciences. And keeping breast with its ever rising academic issues and interests, especially when it comes to the students in cardiology, we are here again with the best of the faculty at hand today. We have amidst us none other than Professor Jyotsna Madhuri. We know she is the founder, patron, and advisor of WINCARS, and we know how much keen passion she has for teaching when it comes to students, and especially in the clinical fields. We are also honored to have amidst us none other than Dr. Zulfikar Ahmed, Chief of Pediatric Cardiology, KIMS Health Pediatric Cardiologist, Lifeline Heart Institute, Edu. Thank you so much, sir, for taking out your precious time for the benefit of students in cardiology, not just for WINCARS, but pan India and globally. And
Thank
of
you.
course, our very dear friend and an honored cardiologist from MKCG Medical College and Hospital, professor and head department of cardiology, Dr. Chabi Satpathy, who was so prompt in acknowledging when it came to the work of students and their clinical teaching. Thanks, Dr. Chabi, for being here with your students. And now I ask Dr. Samvya Kasturi to kindly start the session.
Good evening, everybody. As we all know, we are doing the case presentations once every month. The presenting PG is Dr. Shovan Kumar. He's the final year resident from MKCG Medical College. He'll be presenting the case, and the examiners are Dr. Jyotsna, Dr. Chabi Satpathy, and Dr. Zulfikar Ahmed. Let's start the case without much delay.
Yes, ma'am. Very good evening to respected teachers and judges. Today I am going to present a case. My patient, Mr. Ravindra Behra, who is a 40 years married male, resident of Ganjam district, studies till 8th class with low socioeconomic status, presented to our hospital with chief complaints of distension of abdomen since 1 year, breathlessness on exertion for 5 months, swelling of both lower limbs for 2 months. Coming to the presenting illness, according to the patient, he was apparently well 1 year back when he developed abdominal distensions, which was insidious in the onset and gradual in progression. He first noticed as feeling of abdominal fullness with early satiety. Initially, the abdominal distension was mild and intermittent, but over the following 6 months, it progressively increased in severity to an extent which caused his problems and difficulty in doing daily household activities. There is no history of nausea and vomiting, diarrhea, black tarry stools, yellowish discoloration of eyes, or pain abdomen. Since last 5 months, he developed breathlessness, which was insidious in onset and gradual in progression. Initially, symptoms occurred only during heavy physical activity as he is a manual laborer, but later he became symptomatic while climbing one flight of stairs. That suggests progression of symptoms from NYHA class 2 to NYHA class 3. It used to get increased on exertion and was relieved by rest and not associated with cough and expectoration or any seasonal variation. There is no history of paroxysmal nocturnal dyspnea or orthopnea. Approximately 3 months later, he developed swelling over his both lower limbs. It was insidious in onset, starting around the ankles and gradually progressed up to shins. The swelling was pitting in nature, painless, symmetrical, and it increased on prolonged standing and in evening time with slight reduction in lying down position. It was not associated with facial puffiness and reduced urine output. And because of these symptoms, he was referred to MKCG MCH. There is no history of palpitation, syncope, or chest pain. Also, there is no history of difficulty in swallowing or hoarseness of voice. No history of prolonged fever, skin lesions, or joint pain. No history of any limb weakness, altered sensorium, slurring of speech, pain in the extremities, diminution of vision or blackening of fingers. No history of intermittent claudication. There is no history of tingling or numbness in the limbs. And also, there is no history of bluish discoloration of skin or mucous membrane in the childhood, failure to thrive, or any episodes of heart failure or hospitalization in the past. Coming to the past history, history of pulmonary tuberculosis was diagnosed at the age of 12 years, and he taken ATT for 3 months, then discontinued. No other history of significant illness or prior cardiac surgery or malignancy or chest radiation in the past. There is no history of any major medical or surgical illness in any family members. Coming to the treatment history, patient was treated with oral diuretics with only temporary symptomatic improvement. Coming to the personal history, he is on a mixed Indian diet. His bladder and bowel is regular, sleep is adequate, but his appetite is reduced, and there is no addiction to alcohol. So to summarize my history, is a 40-year-old male with past history of pulmonary tuberculosis, received incomplete ATT, presented with history of insidious onset and gradually progressive abdominal distension associated with dyspnea and swelling of bilateral lower limbs, which shows inadequate response to diuretics without any history of orthopnea, PND, chest pain, palpitation, syncope, presently in NYHA class 3 symptoms.
So, is that simultaneous appearance of both dyspnea and pedal edema or abdominal distension?
No, ma'am.
Which one preceded?
Ma'am, abdominal distension preceded, ma'am.
Why it is important to know about it?
Uh, because abdominal distension in case of constrictive pericarditis, ma'am, suspected constrictive pericarditis, first the patient developed abdominal distension ascites, then patient gradually develops swelling of both lower limbs, ma'am.
Yeah, I request all the students
Pedal
to
edema flatter.
in the chat box.
Shovan, what madam is asking is not about constrictive pericarditis. She wants to know whether are we dealing with a primary right heart disease or a left heart disease.
That is the better terminology,
yes.
as Sir said. So you should say that you wanted to know whether there is a
Don't jump to
disease on the left.
pericardium.
Yes, sir.
That's the reason why I asked, is the abdominal distension is predominant or
Preceding.
preceded or to that of the dyspnea. So now don't use the word constriction because it becomes too early to say the constriction as one of the reasons for the right heart failure.
Yes, ma'am.
So if you think that it is a right heart failure is the predominant disease in this, can you explain the dyspnea?
Ma'am, initially he has class 2 symptoms, gradually progressed to class 3 symptoms, but it was PND or
The question is, Dr. Shoban, the question is, how could you reach at the diagnosis, say, right heart failure? Why it's not a left heart failure? How could you reach there from your history? If it is a left heart failure followed by a right heart failure, or it is a right-sided heart failure to start with?
From the history.
Ma'am,
From
in
the
case
history.
of left heart failure, yes, ma'am. From history, ma'am, in case of left heart failure, the symptoms of dyspnea precedes the symptoms
Of
of
abdominal distension.
abdominal distension and swelling. And there will
So
be
here it is abdominal distension followed by dyspnea, followed by edema. So it's a very tricky area. So you have to answer very carefully.
Yes, yes, sir.
So what do you feel? You would go for right heart disease going into or presenting as a biventricular issue. Because usually what happens is that you start with a left heart disease and goes into right heart problem. Now that is one method. Another route is a right heart disease predominantly. Second one. Then there can be some conditions where you have both right heart problem as well as left heart problem. So
Yes.
among these three groups, which do you think is likely in this patient?
Sir, I will consider it as a right heart, purely right heart failure, sir.
Only purely right heart failure. Then how will you explain the dyspnea? If you say it is class 3.
Dyspnea can be explained, sir, because of decreased cardiac output.
How does decreased cardiac output produce dyspnea?
Because of decreased cardiac output, there will be the respiratory muscles will be supplied less. So patient will feel
Okay, so work of breathing would be more.
Work of breathing will be more, sir.
So you will get dyspnea. But that
Yes.
is the use. That's not the usual cause of a cardiac dyspnea, right? Breathlessness in cardiology is
Yes.
basically we always try to attribute it to either pulmonary venous congestion or hypoxemia. These are the two major causes of breathlessness.
Yes.
So here you have a genuine dyspnea from class 2 to class 3. So you cannot wish away that dyspnea by simply saying reduced cardiac output. I agree, reduced cardiac output will definitely be there.
Yeah, that is one of the good explanations. So is that possible that still it is a left heart disease? How much a percentage of the patients of the left heart disease will present initially as a right heart? In what conditions you expect it? Is it possible or not possible at all?
Yes, ma'am. If there is, in case of RV endomyocardial fibrosis,
That is not a primary left heart disease. I'm talking about a primary left heart disease and doesn't have the features of the left heart disease. What is the major feature of the left heart disease? What is the sine qua non to say that patient has left heart disease?
patient will have history of PND, ma'am.
PND episode.
Correct.
Suppose the patient doesn't have the PND episode.
PND.
Still, I say that the left heart disease is the predominant. Is that possible to present with the right heart failure without any PND episodes? I expect answers from the students also. No one is answering.
Shovan, suppose you are dealing with a dilated cardiomyopathy. What will happen? Usually it will present with left heart symptoms, but sometimes we do see a late presentation, right? They will present with edema and abdominal distension, and then on questioning they will say breathlessness have been there for some time. That is one situation. Then you can have an end stage HCM, no? HCM is a purely left heart disease, but sometimes can present for the first time with edema. Very late in the stage, not in a 40-year-old gentleman, but it's possible.
Yes.
Is silent MS?
Yes, silent, even MS.
Yeah, someone has already answered MS with a severe PAH.
MS with 3 pH.
So how can you explain there? Actually, initially, you expect to develop the PND episodes as as there is increase in the venous congestion. But as a protection, subsequently, what will happen? There is improvement in the PND because of the PAH.
Yes, ma'am.
There are the subgroup, nearly the 5% of the cases of the mitral stenosis can directly go for the PAH without the PND episodes. There you don't suspect it to the MS because predominant presentation is the right heart failure. So it is still possible for the left heart, pure left heart disease to present as the right heart. But as you said, it should be a third in the order when you are saying, like sir is saying, the first should be the right heart, predominant right heart failure. A second one is biventricular, even the left heart involvement and the right heart involvement. Then third can be yes, in only 5% of the cases, it still could be a pure left heart. So now you said that it is right heart. Can you now localize? Is that because of a particular cause for the right heart disease predominant?
Ma'am, I did not get the question, ma'am.
Now you said that it is a predominantly a right heart disease which is responsible for his abdominal distension.
Yes, ma'am.
Okay. What is the important features to say that it is a predominant right heart disease?
Ma'am, the important features is abdominal distension and bilateral pedal edema.
Okay. Now, can you distinguish with this type of the pedal edema? What is the cause for the right heart failure?
What she's asking is what is the anatomical potential anatomical localization for a right heart failure?
Ma'am, in case of right heart failure, the edema mainly on the dependent portion of the.
No, not that localization. The etiology or anatomical localization. So you have the muscle, you have the valve, you have the coverings, you have the great vessels. So
Mainly, ma'am, it can be at the level of valve also, and also
Which valve? If you present
tricuspid,
with the right heart disease entirely, which valve?
tricuspid,
Tricuspid valve disease, right? Okay, good.
then can be also muscles.
Like,
Yeah,
So the better thing is always classify. Then it becomes easy for you to talk about it. Like you already mentioned the tricuspid valve. So disease of the tricuspid produces it. As sir said, muscles of the right ventricle. And still you go proximally if you the pulmonary arterial hypertension or the pulmonary stenosis. So you think about the conditions like that, then you know that what are the predominant conditions. So you give the one example. As I already said, PS and PAH, forget about that. And muscle disorders, what do you think about the muscular disorders which is responsible for that? Either direct muscle involvement or the restriction to the muscle.
Ma'am, restriction to the muscle and also deposition diseases of the muscles, ma'am.
Okay.
And also in case of myocardial fibrosis also
When
responsible.
you started with the constriction, you don't want to get that now as a DD for this at all.
So you do multiple layers, no muscle we have finished, then pericardium also, no, right?
Yes.
Well, so it's a, no, you were saying something about fibrosis. What fibrosis do you mean? Endomyocardial fibrosis, right?
Endomyocardial fibrosis, sir.
So it is another kind of restriction, which can be either predominantly right-sided or predominantly left-sided or biventricular. So that can come as an important possibility of a primary right heart problem.
Right,
Tricuspid valve, muscle, EMF, then your pericardium is also right.
Yes.
And madam was saying about the distal one, that is pulmonary stenosis, pulmonary hypertension, which is a totally different area, but still you should think about it. That is
Yes.
what actually you have written on your slides. Very interestingly. Only thing is, at this point, when you take the history and come up with a summary, this would be too presumptuous to say all these 5 points. Because suppose it happens to be a pericardial disease in an examination setting, the examiner will be little suspicious. You understand? So you have to say basically right heart, left heart, both or whatever, and then offer the possibilities. But your possibilities are right. I agree.
Yes, sir.
out of the
You said
differential diagnosis you are saying, responsible for mainly a right heart failure, how could you reach it's a pericardial disease? Why not a myocardial disease or a valve disease or a PH or COPD PH? These are all causes of right heart failure.
Yes, ma'am.
So how to get the sequence? Which one will come first? Which one will come later? These are all causes at the valve, at the artery, at the ventricle, at the muscles, at the valve. So how could you reach it's a pericardium? Why it is one?
Ma'am, as I said in the history, treatment part of the history, his symptoms are not improving or inadequately improved to diuretics. So I will consider this constrictive restrictive as
Diuretic
past.
resistance, there should be a real documentation of the how much diuretics you given and how much of urination it is produced. Then only you should use the word that not able to respond to the effective dose of the diuretic. Suppose I will simplify your question. Do you consider with this type of presentation PAH with an RV failure? What is one of your DD? Do you consider this? Why you kept that as a fourth cause?
Ma'am,
What make you to think that some other disease is predominant than the PAH with an RV failure? Actually, your third component should be the fifth component. Fifth should be third. It's okay. Why
see,
you are PAH to the RV failure, congenital heart diseases, you are keeping as a less
Yes.
likely than other two conditions?
Ma'am, in these three conditions like asymptomatic congenital heart disease and PH with RP failure, they will respond to diuretics well, ma'am.
Please forget about it. That's what statement I gave it. Diuretic resistance requires a definite quantity of the diuretic use and the response to that, which you are not sure on the history. Okay. And
Yes.
you can't take the rely on the patient history that, yes, I'm taking a diuretic. I take ourselves, you imagine, if you have excess urination, we don't take it. If it's otherwise, they will take it. It's a common. So unless you supervise both the amount of the diuretic given and the response is occurred, you can't say that. Okay.
Yes, ma'am.
Now,
Well,
dominant distension versus
yeah,
pedal.
one point, sorry. One point that you have mentioned, I think will help you know. 40-year-old male with a past history of pulmonary tuberculosis
Right.
receiving incomplete treatment. So that should probably point to a potential pericardial disease. Because if at all you are thinking of a pericardial disease, it is likely to be constrictive pericarditis. And you know, in India, at least half of constrictive pericarditis is due to
Tuberculosis.
tuberculosis. So that from the history, you can probably tell in the examination.
And abdominal distension versus predominant than versus the pedal edema. That is a feature of these patients of the constrictive pericarditis. Isn't that so? And organic tricuspid valve involvements. This is learned in MBBS days. If the predominant abdominal distension than the pedal edema. If there's a diffuse involvement of the pedal edema, both lower limbs and the abdominal distension, then is more likely the PAH with an RV failure or the congenital heart diseases RV failure, which is very, very rare condition to have that too you are saying a pre-tricuspid shunt with an RV failure. It is possible in the elderly age group, but doesn't happen in the younger age groups. So that will give a clue to you.
So one we have mentioned, Dr. Shovan, that abdominal distension came earlier. That's the one point. And number two, you should have hammered, he was case of tuberculosis on ATT, regular, discontinued later on, he developed some restrictive physiology. So you are giving us number one. That's the second point you have to hammer on. One is abdominal part is more prominent. Number two, he's a old case of tuberculosis, discontinued treatment and presented as a restrictive.
I think so. You should probably present organic tricuspid valve disease as the third possibility, and bring down the 3 and 4 towards the. That is probably it's a right way to look at this.
Yeah, sure. Please proceed.
Because if you say first pericardial disease, and if you don't mention that particular history, it will be difficult for the examiner to assess why are you directly focusing on the pericardium, right?
Yes.
It's not a very common disease.
Yes.
One more thing
go
is
ahead.
Always pericardial disease and restrictive cardiomyopathy, DD. In the clinical, do you wanted to ask anything extra than what you mentioned?
In history, ma'am.
Yeah.
History wise.
To differentiate pericardial disease from your restrictive myopathy, what the clinical hints are going in favor, and what else you want?
Ma'am.
What has helped you? What has helped you to go towards the pericardial disease rather than a restrictive myopathy?
Ma'am, in case of myocarditis or myopathy, there will be history of arrhythmia, palpitations.
What is the incidence of so-called atrial arrhythmias in a constriction versus a restriction?
Ma'am, in case of constriction, the atrial arrhythmia, like atrial fibrillation, can occur
in both. It can happen.
Yeah,
Both
it can
occur. Percentage.
Out of the two.
Ma'am, out of the two, it is more in case of restriction as compared to constriction, ma'am.
How much can present with atrial fibrillation in constriction? How many?
In 20% cases.
Yeah, up to 30. Up to 30, 1/3 they can present. But it is more commoner in restrict. That is one. And what else have differentiated? What else from the history you tell? What else has differentiated?
Ma'am, in case of restrictive cardiomyopathy, there will be history of orthopnea and PND will be there. And,
right. They may present with associated LV problem. They can have it. Right. Next.
Embolic episodes. Usually we never ask about it in the right heart and failures. But embolic episodes can happen in the restriction, but less likely in the constriction. But there is always the controversy because even in the restriction, it's a fibrosis of the apex. So actually, it doesn't embolize very frequently. But because of the contractility, the defect, it is known to have the more frequently than embolic in episodes than that of the constriction.
Yes.
That is one. Yeah, please go ahead for the
Okay.
clinical signs.
Coming to
Go
the
ahead.
yes. Coming to general examination, a patient is conscious, cooperative, and well-oriented to time, place, and person. His height is 173 centimeter and weight is 64 kg. BMI is 21.4 kg per meter square. There is no pallor, icterus, clopping, cyanosis, and lymphadenopathy. Patient is afebrile. There is pitting edema on feet up to shin on both sides is present. Pulse is 80 beats per minute, regular, low in volume. No, there is no special character. Bilateral symmetrical with no radioradial or radiofemoral delay. Blood pressure is 106 over 80 millimeter mercury in right upper limb and 106 over 76 millimeter mercury in left upper limb. In both lower limb, the blood pressure is 114 over 76 millimeter mercury. And there is no evidence of pulsus paradoxus. Respiratory rate is 18 beats per minute, thoraco-abdominal. And his oxygen saturation is SpO2 is 98% on room air in all four limbs. Coming to jugular venous pressure, JVP raised, it is 12 centimeter from the sternal angle. There is normal X descent, but a rapid Y descent, and Kussmaul sign is positive.
So can you go back to the first slide, Shovan?
Yes.
Yeah, you said there was no pulsus paradoxus, right?
Yes, sir.
So why did you look for the pulsus paradoxus? Possibility of which conditions?
Yes, ma'am. Yes, sir. If there is a possibility of tamponade, sir.
No tamponade. In this patient, did you suspect tamponade? Be very careful.
Yes, sir.
In this particular patients, we are discussing three major issues: constrictive pericardial disease, myocardial disease, and PH situation, and tricuspid valve disease. So, in that scenario, why did you look for the pulsus paradoxus?
Pulsus paradoxus can be present if there is both effusive.
Among these three conditions which you are thinking of, which condition can produce pulsus paradoxus?
Sir, in case of effusive constrictive pericarditis, sir, there can be pulsus paradoxus.
Suppose it is pure constrictive pericarditis, can you get?
Yes, sir. There is.
Yeah, you can get. So you have to say, no, these are all simple questions. I think you think that this question is loaded with some ammunition. No, it's not like that.
Yes,
You can expect at least one third you will get the pulsus paradoxus in constrictive pericarditis. Not even with the effusion. If it is there, definitely yes, more likely.
Yes,
How did you assess the pulsus paradoxus? Look for pulsus paradoxus.
Sir, did not get the question, sir.
How did you assess whether there was a pulsus paradoxus or not? Did you
Yes,
look at the pulse or did you look at something else?
Yes, sir. Pulsus paradoxus, when the pulse is.
No, what I'm asking you is that when you want to elicit a pulsus paradoxus scientifically in a subspecialty examination, are you looking for a pulse examination or something else? There's a clue there. What is the definition of pulsus paradoxus?
Sir, if you find in a patient if the heart sound is heard but the pulse is cannot be palpate, then we suspect.
That is the observation by Kussmaul some time back. Now, what do you define? How do you define pulsus paradoxus? Is it based on pulse or BP? I will give you the answer.
Yes, sir.
It is based on.
Yes, sir.
Once you suspect pulsus paradoxus, how could you reach finally it is pulsus paradoxus?
Yeah.
If there is a exaggeration of the inspiratory fall in the systolic blood pressure.
Correct. Absolutely. So that is the answer. Simple. You know it.
Yes.
Only thing is you are mildly stressed out probably because of madam. So you have to see, that's an interesting thing. Even though it's called pulsus paradoxus, by definition, it is an inspiratory fall of systolic BP for more than 10 millimeter or whatever. But what percentage doesn't matter. So you have to do blood pressure recording. But you can get a clue to pulsus paradoxus by palpating the pulse also, right?
Yes.
Okay.
Yes.
Yeah, actually, you can
So there
quantify
was no
the,
pulsus paradoxes.
you
Okay.
can
Now,
quantify the degree
anything
of the
else I
pulses
want?
paradoxes. So that is the most important, na? Not only just a presence and absence. You can quantify what is the degree of the
Quantify.
pulses
Yeah.
paradox.
Yes.
So here it is not due to tamponade. It is, if at all it is there, should be due to a constrictive or a constrictive pericarditis. Is there a different mechanism for pulsus paradoxes between tamponade and constriction,
Uh,
or is it the same mechanism?
uh, the other mechanism is in case of
Soumya, you must be watching over the time, because we, in our enthusiasm
Sir.
to make a show and uncomfortable, we will not think of the time factor also.
Sir,
So,
it's
Anyway,
8 o'clock,
Shovan, the
sir.
point, Shovan, the point is, it's very important, because my teachers used to say that any final year DM resident who knows the restriction physiology or a pericardial disease properly, hemodynamics, he's fit to pass
Yeah.
with some understanding of congenital heart disease.
Yes, yes.
That is the point. So you should go back and read clearly about the mechanism or mechanisms of pulsus paradoxes in tamponade versus paradoxes in constrictive pericarditis. They are little different. You should go, right? Okay, go ahead. It's a very important point. Next slide. Next slide, I want to ask you one question. Yeah, next slide. Can you put the next slide? JVP is definitely elevated 12 centimeter from the sternal angle. So what will be the approximate RA pressure, mean pressure?
RA mean pressure will be sir 17 centimeter, which corresponds to
Which is converted into around 12 or 13, right?
12 or 13
12 or 13 millimeter of
millimeter
mercury. Okay,
mercury.
fine. Yeah,
Yes, sir.
correct. Good. Rapid wide descent with a raised down inspiration. Small sign is also there. Okay. Right.
Yes.
Is this JVP is going to be helpful, because very close DD to always to the constriction is the restriction. So is this JVP is going to be helpful to you to say whether it is a restriction or constriction?
Yes, ma'am. In case of constriction, the X descent will be normal, but there will be rapid Y descent. But in case of restriction, the X descent is attenuated.
Why attenuated? Why not in constriction? Why in restriction? Attenuated.
Because, ma'am, in restrictive, the arterial, there will be arterial muscle of the arterial will be involved. That's why the X descent is attenuated.
Relaxation.
Relaxation.
Relaxation of the atrium as in the ventricle is also affected because myocardium are involved too, and right?
Yes.
Okay.
The Kussmaul sign is frequent in what condition?
Ma'am,
Restriction.
yes. Kussmaul sign is frequent in constrictive cardiomyopathy, but can occur, but very less in case of restrictive cardiomyopathy.
Yeah, the case like this, at every step you should bring the restriction to the constriction. You should say that these points in favor.
Yeah, that is the main.
Yeah, please go ahead.
Okay, please go ahead. Yeah.
Coming to the cardiovascular examination proper, in inspection, the precordium is normal in shape. The apex beat is not visible. There is no other pulsations or venous prominence in the chest. There is no scar mark and dilated vein seen. In palpation, findings on inspection are confirmed. Apex beat is not palpable in both in supine and left lateral position. There is no palpable heart sounds and thrills in hip or rub present. The subsequent impulse is absent.
Okay, go ahead. So nothing great from this percussion.
Should we write the subsequent pulse is absent, or there's no subsequent impulse? As the subsequent impulse is a normal thing. Subsequent impulse, no subsequent. If you say subsequent impulse is absent, means you are searching for it should be present. There's no subsequent impulse.
Yes, ma'am. There is no subsequent.
Next.
In percussion, hepatic dullness starts from right fifth intercostal space in mid-clavicular lining, and the liver spine is 15 centimeter. The left
Which is
second.
normal or abnormal in a 40-year-old? That's the point. That's the point we
Yes,
want to make.
yes, sir. It is abnormal.
You think it is abnormal. So what
Yes.
is the range for an adult male?
It is 8 to 12, sir.
So this is a little more than what you expected. Okay, go ahead.
And the second left intercostal space is resonant. On auscultation, the first heart sound is normal. Second heart sound is normal intensity and splitting. And there is no S3.
No, you should not say like that. You should first say whether it is splitting or not. Then you comment on A2 and P2. That is the standard way. So what is your comment now? Now that we have told you.
Before
Is there a splitting?
Before auscultation,
There
I
is
wanted to ask one
normal
thing.
split.
Normal split. You are saying it's a normal split. Then you should comment on A2 as well as P2. That is very important in this situation because you have to distinguish between a constrictive pericarditis or a restrictive cardiomyopathy. It becomes very crucial.
Yes, sir.
So,
in my patients, sir, the A2 is normal intensity. Also, the P2 is
P2 is also normal. So, as
intensity.
madam was asking, that second sound, does it help you to move towards constriction or towards restriction?
Sir, in the second heart sound, if it's the P2
In this patient, is your description of the second heart sound, does it favor a constrictive physiology or a restrictive cardiomyopathy?
Ma'am, sir, in my patients, as the split is normal and the A2 P2 is normal intensity, it favors towards constrictive.
You said no, don't comment on A2. You comment on P2 because most of
yes,
the
sir.
RCM will have PAH.
Yes, sir.
Constrictive pericarditis will have no PAH generally.
Yes,
Right?
sir.
So that is the point. Rather than saying A2 and P2, you should focus on a particular finding.
You better say the P2 is of normal intensity.
P2 is
That will
normal
help you more.
density. Yeah, correct. Then S3 and S4 are absent. Okay, go ahead.
There is a pericardial knock of high-pitched early diastolic sound at left lower sternal border, west heart with the diaphragm in the supine position, sir.
Okay. How are you sure that this is a pericardial knock? What is the other early diastolic sound that you know of?
Sir, S3 and
No. S3 is not a early sound. It's a middle sound.
Early diastolic sound can be opening snaps, sir, also.
Opening snap. So how can you distinguish this from an opening snap?
Sir,
because madam was telling about the silent MS with severe PH, right heart failure.
The opening snap. Yes, sir.
Yeah, tell me, please. Go ahead.
In case of opening snap, there will be the S1 should be loud, sir.
Yeah, here it is. S1 is normal in an MS. So that's a very indirect support, but I agree with you.
Yes, sir.
Now, okay, right. Now, you are saying no S3 and you are saying there is pericardial knock. So actually pericardial knock is actually it's a what you call as a modified S3 or S4?
Sir, actually pericardial knock is a modified S3, sir.
S3. It's an early S3 with a higher pitch. So it would be safer in the examination either to say say no S4 heard, then I can hear a pericardial knock, or in a different way that I can hear an S3 which is high pitched and a little early, and say it is probably a pericardial knock, because some examiners may find it objectionable when you straight away say pericardial knock.
Okay.
So many times what happens is that you do a final diagnosis of constriction by CT or whatever, then you go back and see, okay, that the early third sound which I heard was probably a pericardial knock. But I agree, it's a higher pitched earlier, but early cannot be.
And actually,
So you're saying pericardial. So you reached the diagnosis. Okay,
there are differences between the pericardial knock and opening snap. As a final year student, we expect to say each one of that actually. It is a high pitched and then that is a sharp one. That is one of the distinctions. Other one is it is a relatively earlier, whereas the pericardial knock it is about 90 milliseconds to the 120 milliseconds. Whereas this is slightly the later. It is varies between the 50 milliseconds to the 120 milliseconds. Yes. So the timings is, even though it is not possible clinically for you to say it, But you have to compare, as sir is saying, with this and how far is from the next two.
Yeah.
That will make whether it is slightly the earlier, the slightly the later.
Yeah.
And of course, it is an associated findings are the much more important. Like a presence of the kusmal, it is more of a constriction. A presence of the diastolic in murmurs goes in favor of opening snaps. All those things you should able to list it out once they say what is the distinguishing features.
Differentiating between your pericardial knock and your opening snap, you must know what all the associated features and timing too. Following second heart sound, what is the sequence? When will the pericardial knock come? When will the opening snap? And what are the all associated findings? Except S1, what you told. We should also mention all associated findings. Why I'm going towards knock? Why not its openings?
And it is bested in the left sternal border.
And that will go towards
that
the
is
apex.
the apex. Even site of bested is also varies. Okay.
And your maneuvers,
Shovan,
your respiration.
Shovan, you think you must know that this is a very simple thing which you should know. Everybody should know. Postgraduate should know. That is, in the chronology, what you call as opening snaps come first, then pericardial knock, then S3, and then S4. So S3 is actually a middle sound. It's not an early sound.
Yes.
That's very, very crucial in the examination or real life also. It's very important. Okay, go ahead.
Yes. Coming to the other system examinations.
No. You did not mention anything about murmur or lack of murmur or presence of murmur. You cannot see. After all, cardiology is all about murmurs. So you have to tell us whether there is a murmur or not.
No, sir.
You should specifically say there is no cardiac murmur, because if you don't say no cardiac murmur, if at all there is no cardiac murmur, the examiner or anybody will feel that you are fixed on the diagnosis of constrictive pericarditis, because your alternate diagnosis would be a restrictive cardiomyopathy, which can generate murmur, right?
Okay. Yes, sir.
So which are the murmurs generated by a restrictive cardiomyopathy?
TR murmur and also
TR murmur and MR murmur. No?
Yes.
So that is very, I think you should specifically say, I could not hear a murmur. Okay.
Important negative findings should also be mentioned.
Very, very
there.
important.
I do not have murmurs means I am ruling out restrictive cardiomyopathy, most likely. And can constriction produce a murmur at all?
Yes, correct.
Constriction.
Constrictive pericarditis, can it produce a murmur at all or no? 100%.
What is focal constriction?
Suppose you have a localized constriction around the AV groove. What will happen?
The AV atrioventricular groove constriction, we can have
it's stenosis.
Yeah.
So it will sound like a mitral stenosis or a tricuspid stenosis. So that is also possible. Possible, but can even you should know that in a late point, this is only relatively 2-3 years now history. In a late constrictive pericarditis, sometimes what can happen is that there can be an LV dysfunction, which can also produce a MR murmur, but a faint murmur. But generally, you don't get a murmur in constrictive pericarditis. Okay, go ahead. Then quickly go through the other systems, and then we will go, because it's already 8:15.
Other system examination, abdomen is liver is palpable. It is 4 fingers below the costal margin. It is non.
Why should you say 4 fingers and all? You don't have a tape? Don't say 4 fingers. Centimeter. No, everything in centimeter. No, your JVP is in centimeter. This has to be in centimeter. Anyway, lesson 1. Shifting dullness is present.
In this case, do you do the hepatojugular reflex?
Yes, sir. Because
it is contraindicated. Already your JVP is elevated with 12 centimeters. So that itself is a right heart failure. So what you have to do? What is the reason of doing a hepatojugular reflex?
To
See
detect
that the further increase in the venous pressure occurs or not when it is not elevated. And this is a relative contraindication to do it.
Yes.
So did you understand that point? 2 points actually. She has mentioned 2 very important points. If JVP is elevated, there is no role for abdominojugular reflex. 1 point. Second is that in this patient who has a tender liver, it's no non-tender, but still you should not unnecessarily cause discomfort to the patient. Actually, where do you press to assess the hepatojugular reflex? Which part of the abdomen do you press? Is it a right hypochondrium or the central position?
Sir, in central position, sir.
Central position, not in the on the liver, because it can cause discomfort. So, it is what you are planning to do is to increase the intra-abdominal pressure and increase the venous return into this. Okay.
Yes,
Are you trying, Shovan, to find out this hepatojugular reflux in this patient? Are you trying to find out?
ma'am, as the ZVP is already elevated, so
This one, that is for occult failure. We
yes,
do
sir.
not have any suspect.
Yeah, that's
Right.
so don't do that, right? Okay.
There is no splenomegaly, and the umbilicus is inverted. And coming to the respiratory system examination, trachea is central, bilateral air entry is
The
normal.
umbilicus is everted or inverted?
Inverted.
Normally, umbilicus is inverted. Everted, you meant. Anyway, go ahead. Listen, man.
The respiratory system examination, trachea is central, bilateral air entry is normal, equal, and normal.
Fine. Final diagnosis.
So my final diagnosis is chronic constrictive pericarditis, likely tubercular in etiology, currently in NYHA class 3 symptoms, in normal sinus rhythm, with no evidence of pulmonary venous hypertension or pulmonary arterial hypertension.
So clinically, how do you look for a pulmonary venous hypertension? I agree that there is no pulmonary arterial hypertension based on your physical findings. That I agree. But you are specifically saying that there is no evidence of pulmonary venous hypertension. How can you pick up pulmonary venous hypertension by either history or physical examination?
So in case of pulmonary venous hypertension in history, patients will have dyspnea. So
yeah, does this child have dyspnea? He has class 3 dyspnea, according to you, right?
Yes.
So that is one of the major factor which tells you that there is some evidence of pulmonary venous hypertension. Otherwise, how can you explain that simply by the reduced cardiac output you cannot explain? And you understand, even though it's a constrictive pericarditis with a low cardiac output, low probably fixed cardiac output, you can have this respiratory muscle fatigue and all, but that may not explain the genuine dyspnea. Genuine dyspnea has to be due to some degree of pulmonary venous hypertension. What does that mean? Basically, whenever you are saying constrictive pericarditis and you have the right atrial mean pressure of around, what was that? You said 12, 13. What will be the left atrial pressure usually in a constrictive pericarditis? Logically?
Logically, it should not go beyond 25, sir.
It will be more or less equal or slightly more, right?
Yes, sir.
Why 25? Why are you suddenly jumping at 25? We are not talking about in constrictive pericarditis. If the RA pressure is given, how will be the LA pressure? Your RA pressure is around 11 or 12. 11, so LA pressure will be around?
Around 12. Around 12 or somewhere within 2 or 3 millimeters of mercury. Yes. So maximum you can expect is around, let's say 50. So what does that mean? If an LA pressure is 15, pulmonary venous pressure will be 15. So 15 millimeters of mercury is enough to produce a exertional dyspnea. So you can explain easily that because of dyspnea, because JVP is a very important point in constrictive pericarditis. If you are getting a genuine mean pressure of RA, you will get the mean pressure of L, which will be within 2-3 millimeters of mercury. Yes. That is the logical approach to physiology, pathophysiology. Okay.
Is constriction, constricts both right ventricle and the left ventricle. So it is not that expansion of the left ventricle is going to be the normal. Because of the right ventricular, the pressure, the thickness is the small, it is have an effect on the interventricular septum, and it is has an effect on the left ventricular output. But otherwise, even the left ventricular expansion is going to be then affected by the constriction. It is a closed case. And in some cases, they will demonstrate even increase in the left ventricular end diastolic pressures. If you do the cath, there is an equalization of all the pressures.
Yes, ma'am.
So that itself says that there is increase in the pressure.
So you could probably say that there is some evidence of pulmonary venous hypertension based on the history as well as the physical finding, and there is no pulmonary arterial hypertension. That we would agree. Right.
All the more reason when the PAH is not there and the left heart signs you are not able to say it, the dyspnea you can explain only by the pulmonary venous hypertension. Of course, as you said, respiratory muscle weakness also can produce it, but that is a secondary. So you should say that the pulmonary venous hypertension. Yeah, please go ahead.
Yes, ma'am.
Yeah, sure. Go ahead. No problem. I think we have reached because there are all through your history and your physical examination, everything points to a chronic constrictive pericarditis, starting from the history of a poorly treated tuberculosis to history, pulse, BP, JVP, and the cardiac palpation. Everything points towards the constriction. So there is hardly any room left for restrictive cardiomyopathy.
Yes, sir.
Okay. Anyway. But now, would you like to rearrange the previous ones? First, you said chronic constrictive pericarditis. Secondly, is there an outside chance that this could be a restrictive cardiomyopathy? And what is the importance of deciding between constriction and restrictive cardiomyopathy? What is the relevance to the patient?
Relevant to the patients.
What
Got
benefit will,
Shovan, you
because
got the
both are
question?
restrictive.
Why you are differentiating? Any difference?
Yeah.
If you
Why are
differentiate
you
this is
differentiating?
constriction versus it is restriction, it is
Restriction.
beneficial
What is,
for the patient.
yes.
Which way?
In regarding the treatment part, in case of
Constriction.
pericarditis, constriction,
Mm.
the prognosis is better.
Why?
Why
Because
you tell exactly why?
Why?
because there is a
That is what
treatment.
there is a treatment. What treatment?
Uh, that is it
For
can
constrict
be
pericarditis?
Do not be hesitant.
Yes.
You know it. I know it. I know that you know it. What is
the treatment like can give
not like
NSAID,
not
NSAID,
like treatment is what is it?
What exactly is the treatment for
in case of
pericarditis, chronic constrict
Constrictive
pericarditis that is not available with restrictive cardiomyopathy?
sir, that is pericardectomy, sir.
Yeah,
Yeah,
we have to give a
correct.
quick
Absolutely.
answer. The secure if you give a
It's
constrict
secure for
pericarditis.
them, no? It's almost near cure for it. So whereas RCM, you are saying that you have limited lifespan, cannot do anything much, not even drugs, no? Compared to DCM, we are in a very badly disadvantageous position in treating restrictive cardiomyopathy. In fact, this morning I had seen one girl who is 7-year-old having severe restrictive cardiomyopathy with severe pulmonary arterial hypertension. Nothing we can offer, only diuretics and whatever. Not even pulmonary vasodilators, because pH is due to the restriction, not because of the inherent pH. So it is very important to the patient to make sure that this is constriction. Very important. Okay.
Yes.
Now, what is the next step, Soumya? He has made a diagnosis.
Sir,
Lab
the investigations.
Yeah, correct.
Coming to the laboratory investigations, CBC showing 11, hemoglobin is 11.2 and TLC count is 7,900. Platelet is 2.9 lakhs per mm ESR is 38 and CRP is 8 milligram per liter, a little bit higher from the normal.
Okay. Right.
Uric 38, creatinine is 1, sodium is 133, potassium is 4.1, and total bilirubin is 0.9. AST is 42, ALT is 38, and ALP is 142. Albumin is 3.4. His troponin is less than 0.04 nanogram per ml. NT-proBNP is 92 picogram per ml.
So these values, they are not very crucial, but do they you can say something? Does it do they convey something to you?
Yes, sir. In case of restrictive, the NT-proBNP level is high. Maybe high.
And in both constriction and restriction, there can be some liver injury, but here liver injury is not there. No, there is no transaminase elevation. Okay.
Yes, sir.
Yeah.
Anything important?
Next.
You just highlight what is important. Don't tell all the normal. What is important out of the investigations? NT-proBNP is normal. Okay. Tropa is normal. Then
the next is, ma'am, the ESR in CRP. as these are a little bit higher from the normal value. So it indicates there's some kind of ongoing inflammation is there. And so
Possible. Okay. Right.
yeah.
Okay. Right. Next slide. Next.
Coming to the ECG.
Yeah.
Can
you quickly read that? Yeah.
Yes, sir.
Standard reading.
This is just 12 ECG with normal standardization with with a normal speed.
Rhythm.
Yes, and
Rhythm.
rhythm is regular, sir. Rate is 80 per minute, and QRS axis is around.
Now, before that, you have to think about the P wave. Never forget the P wave and the PR interval.
PR interval is normal, sir.
Now, what about P wave?
P wave is, sir,
normal or abnormal? That's
normal.
all.
Normal, sir.
Normal. Okay.
Normal.
Can you expect something in P wave? In constriction versus RCM?
Sir, in case of restriction, there'll be bilateral enlargement.
Yeah,
So,
correct. So if it is not there, you are again more in favor of, by default, it is more in favor of a constrictive problem. Okay. Then PR interval is also very important because sometimes in constriction also you can get a prolonged PR interval.
Yeah,
okay. Then QRS
And your
with
from QRS?
Sir, madam, in QRS, there will be low QRS voltage, sir. But here it is not
Otherwise.
there.
present.
How do you say it is a low? So how do you define low voltage complexes?
Sir,
how do you make out low voltage?
Yes, sir. In case of limblets, if it is less than 5, and in case of chest plate,
total QRS, a bit less than 5, and precordial less than?
Less than 10, sir.
Yeah, correct. Very good. Here it is normal. Good.
Not
then
normal.
R by S in V1 is normal. Everything is practically normal. No?
Only there is a non-specific T inversion in 3 and AVF.
3 and AVF. Yeah, flat. Okay. Not much. Yeah, some difference. Okay. But there is no gross difference. What do you expect actually in a constrictive pericarditis? ECG will be almost like this most often, right? Okay.
Yes.
Unless if there is an atrial fibrillation or whatever, right?
Yes,
Next.
Sir.
So between ECG and X-ray is going to be more important.
Yes, sir. This is a chest X-ray PA view and so a left lateral view showing there is no bony abnormality and with a normal exposure.
Talk about the heart time factor. Yeah.
Yes, sir. There is no chamber enlargement or cardiomegaly. But
no cardiomegaly and chamber. First you say cardiomegaly, no cardiomegaly, and no definite evidence of chamber enlargement, right atrium or left atrium. Okay.
Yes. There is presence of pericardial calcification. Can say.
Where is it?
Sir.
Laterally, medially, or infra below? Yeah. There is a pericardial calcification.
Also in lateral.
Okay. So basically, we know it's very classical, no? Because the constriction, the calcification is maximally in inferior margin and well as the RV free wall area, right? Why did you take a left lateral?
Because the
I think you should, but why? What is the reason?
Yes, sir. The pericardial calcification is better seen in left lateral view, sir.
Where? Why take a left lateral? Why take a lateral view?
To look for the
correct.
RV, sir.
Correct. RV calcification. Correct. Absolutely. Right. Good. Well, is there any PVH? Pulmonary venous hypertension?
Sir, this X-ray, there is is a present.
No, you come in whether it is no PVH or PVH.
The PVH is
yes, there is some suggestion of an upper lobe pulmonary vein.
Yes.
Yeah, the mild PVH maybe. Anyway, PA is normal, aorta is normal, right? Go ahead. So you are almost reach the final diagnosis by X-ray. X-ray is much more important here than this thing. Right. Then the standard question the examiner will ask you is that in constrictive pericarditis, what percentage of constrictive pericarditis will have pericardial calcium visible in X-ray, CT, etc.
So in 50%.
Correct. Very safe.
Yes.
Right. In echo.
In echo, sir, it is most. It is
approximate.
Approximately, sir, in 60%.
Safer value between 50 and 100. So it is somewhere around
60, sir, 60%.
75%. Okay. Then they will ask you, suppose you do you are adventurous and do a transesophageal echo, which you should not actually. If at all you are doing a transesophageal echo by fault or default, will you get a higher what rate of picking up? And the answer is there in the question. It will have a slightly higher chance of getting it. But that is not to say that you should do a TE. Don't do a TE. Okay. Then next, other investigation.
Sir,
so you are almost sure, you are almost reached the. Okay.
Sir.
What is this image?
The CT.
It's a CT image.
Yes, sir.
So suppose I say that this gentleman is only 40, but still I would rather not give him what you call radiation. Yes. And I would prefer a CMR. How will you answer my question? How will you defend your first choice of CT?
Because sir, CT is more sensitive to detect pericardial calcification.
And thickening. Even thickening also it is more sensitive, and calcium, both. Correct.
Why diaphragmatic calcification is more frequent?
Yeah.
As you said, the lateral view you are able to see it much better one. That is because the diaphragmatic surface involvement. So why in a constriction the calcification is more likely to be there?
What is the difference between inferior surface versus the other surface? Why more of calcium develops there? How has been the heart fixed inside the mediastinum? Is it through mobile structure, or we have some like adhesions or like restrictions and fixations so that the heart will not move this side? That's it.
Sir, ma'am, because the diaphragm site is less, the movement of heart is less as compared to the LV side.
Why? Where is the heart fixed to the surrounding structures?
Posterior and the
three sides where the heart is fixed. One is towards your vertebrae, one is towards your sternum, one is inferior in the diaphragm. These are the structures where they're fixed, they are not moving, right? So any relevance to calcium?
So I think you will find out and tell ma'am. Okay, go ahead. So there is calcium here, there is thickening there. What was the report? How many millimeters and all?
Ma'am, sir, it is more than 5 millimeters.
5 millimeters. Usually should be less than
2
millimeters. If it is 5 millimeters, you are almost sure that this is a constrictive with all the clinical findings and all. Now somebody says that I want a CMR also. Suppose I am in favor of an additional CMR. Would you like to do a CMR in this patient? Yes or no? Quick answer.
Yes, sir. To look for it. Yes, sir.
Look for it.
Any ongoing inflammation, sir. Active inflammation is there.
Very good. Super. Very good. So suppose it could be still a initial, if you see constrictive pericarditis leading on to a constrictive pericarditis, some inflammation. Yes. And yeah, that is the. And of course, always RCM is in your back of your mind. CMR may be helpful, but probably in this patient, I think CT would be enough before surgery. Okay. Yeah. Any other images that you have with you? Echo card. Yeah. Why did you pick on CT before echo? Because whatever said and done, So, because it is very important, see, somehow cardiologists have salvaged echocardiography and did not allow the radiologists to take it away, because both CMR and CT has been taken away by the radiologists. The only major weapon you have in your hand, I mean, non-invasive, is a echo. So you should say start with an echo. Okay,
Yes.
tell me.
But sir, they are
Read the
fighting
echo.
a lot. They are fighting a
Yeah,
lot to take echo also.
exactly, correct.
The TE they have already taken, I think.
Already taken.
Anesthesia
Yeah,
people
correct.
they have taken. And TT they are fighting, the radiologists.
Yes, yes. Radiologists have combined with anesthesiologists to deprive our only pressure in doing it. Anyway, you go ahead and read about this. Read this in a 2D view. What is your you are making a diagnosis of a constriction. What do you expect in a 2D?
Sir, in 2D, this is the apical four-chamber view showing septal shudder.
Yeah,
And
correct.
yes, sir.
What is the other word for septal shudder?
Septal splash.
Bounce, no? Anyway,
Bounce.
Bounce, sir.
Bounce is the typical one.
Yes,
Yeah.
sir.
Bounce are
Then-
short.
Yes.
Yeah.
Here in the it is
Contractility is normal.
yes, sir. It's
What
the
about
M mode is
yeah.
showing
No,
pericardial
in 2D itself, you should look for a pericardial thickening, no? Is it convincingly thick or
in 2D,
you are
sir.
not sure?
Yes, sir. It's convergent thick, sir. Thick, sir.
Yeah,
It is
the is thick and all.
5
Okay.
mm.
And okay, what about the left atrium?
Left hand relatively enlarged, sir.
So,
Yes.
because of the elevated LA pressure, no? LA pressure. Okay. M mode?
M mode is also showing, sir, the pericardial thickness is 5 mm.
Then what else? What else will you look for? What
Here
else will you look for in a 2D apart from the septal bounce or shudder? What else? During systole, what should happen in a constrictive pericarditis sometimes? In a constrictive pericarditis sometimes, not always, but sometimes. Because of Madam was saying about the interdependence, what can happen? The IVS may bulge towards the
there will be respirophasic.
left ventricle.
Yes, sir.
Towards the left ventricle.
IVS will be respirophasic, sir. In case of.
So
What
M
is the
mode
basic
comment on
difference, Shovan? Your
Yes.
septal bounce versus your respiratory dependence of IVS. Is there any difference or is all the same?
Sir, ma'am, septal bounce it is different. It is different
from
the normal septal
deviation.
sir. It is exaggerated version of the.
What it hints at? You have a septal bounce means what?
The septal bounce means the IVS as the intrathoracic pressure is not transmitted to the chambers. So the IVS during inspiration, the IVS will be shifted towards the left.
I think you are confused. I think you are confused. Your dependence, interdependence of the ventricles and the septum moving this side, that side with inspiration. That's a different thing, and septal bounce is a different thing, right? They are not the same.
Yes, sir.
They are both totally different. They're two different pathophysiology. So you should again go back and read about the difference in pathophysiology of septal bounce versus that deviation of the interventricular septum. Okay. So M mode, anything very important? Thickening, you said. Anything else should you look for? What is a very important finding in M mode? Because nowadays M mode is like almost going into oblivion by the echocardiography. So, but still here it is very important. Apart from the thickness, what else?
M mode also you can see the septal shudder, sir. So
okay, so that can be there. Okay.
Yes.
What about the posterior? Doesn't matter. Next, any other images you have? Did you look for a MR or something by color?
No, sir. There is no MR or TR, sir.
There is no MR. There is no TR. There is no pulmonary hypertension.
Hypertension, sir.
Any other images that you have with you?
Yes,
To
sir.
show us?
Yep.
Yeah, this is very correct.
taken the E by E ratio. It is closely 1.97, sir.
Okay. So
So
what do you expect in a constriction?
it is more than 2, sir.
Yeah, approximately more than 2. So he is almost right. So anyway, it's a 40-year-old male. This itself is definitely significant. Okay, what else? What other parameters?
We have
Yeah,
taken
what is
the
this?
tissue velocity.
Mm.
There is here the medial tissue velocity is 13, and the lateral tissue velocity is 10, which shows annulus reverses, sir.
Annulus reverses.
Yes.
Okay, good. So, Shovan, see, I realized that you are good in all this evaluation, that is imaging evaluation, all those things. But I think you should go back and be a little more strong in the clinical evaluation, right? That is also that is ultimately the examiner will not see you. Are you a very good interventionist or a echocardiographer? They will basically ask you simple questions like JVP and all. So, must be very. But anyway, I agree. There is what is it called pulsus reverse. What is it? What does that say? You said annulus reverses, alle?
Annulus reverses, sir.
What is that mean? What does it mean?
Normally, sir, the medial lateral annulus is annulus velocity is more than the medial annulus velocity, but in
Here it
case
is the other
it
way.
is reversed, sir.
Okay. Is there any other thing regarding annulus? Something like what? Like
Yes,
our pulses, paradoxes? Is
yes,
there
sir.
something?
There is also in constriction there can be annulus paradoxus,
Mm.
which is annulus paradoxus is, sir, even if the E by E prime is uh,
Mm.
more than,
Correct.
but the venous pressure will be less, sir.
Not exactly. You're
LP
not sure. You are not sure. I think you should go back. But again, this shows definitely a medial annular velocity is high. Any other slides?
And the velocities are maintained, right? There's no
Yeah, it's the
reduction
main.
of the
Well,
myocardial
there is no
velocity.
reduction,
So that
correct.
you are excluding each phase, you are excluding restrictive cardiomyopathy.
I think it's a very good illustration, no? Starting from the history, I think it's a genuine illustration of making a diagnosis clinically, making a diagnosis by a simple X-ray and ECG, and then going over to echo, advanced in echocardiography. I think it's great, and then finally go to the imaging. It's good. All what is missing is probably we basically in this particular situation. I don't think there would be a need for a cardiac catheterization,
Yes,
right? Any
Any
other
other?
images you have?
yes, sir.
Uh,
Yes, sir.
Okay, right.
This is
Tell.
the there is this is the mitral E velocity seen in both inspiration and expiration. There is decrease in the mitral E velocity in during inspiration. It is the variation is more than 25%, sir.
Okay. Whereas in RCM, what will happen? What can happen?
Sir,
In RCM also, E velocity is more. So what is the difference?
the variation
Will be
is
less than
25%.
it will still be variable, but less. Okay.
Less than 20%, sir.
Yeah. Good.
We have taken
Yes.
uh,
The end game.
yes, sir.
Okay. What is?
It's the global longitudinal strain. Even
Yeah.
if even if the average strain is preserved, but there is strain reverses seen here. The lateral strain is uh, less than the septal or medial strain, sir.
No, I'm not good in this. Okay, so can you teach me in 2 minutes? Quickly, what is the interpretation in this?
Sir, it is the global longitudinal strain.
Yeah.
The
GLS.
so in case the
Is
the
this more important for RCM or
yes, sir. In
constrictive
case of RCMP, the average global longitudinal strain will be normal or decrease, sir.
Okay. In
But
constrictive pericarditis?
There will be strain reverses because the lateral strain will be less as compared to the medial strain, sir.
Better you
Is
say
it
in
there?
restrictive cardiomyopathy, the GLS, if you take regionally, it's decreased everywhere. Myocardium is involved everywhere. And the total average GLS is reduced, right? But
Yes.
in constriction, like your annulus reversus, because the lateral side is tethered, there only there's a reduction of contraction. It is less negative versus that of septal, which is preserved.
Yes, ma'am.
So that
That is how,
same as your
that
tissue
is
Doppler, same as your tissue Doppler, it's just another
same
version
answer.
of that, right?
This is the kind of answering you should acquire in the examination, correct? And yeah, and then naturally what will happen is that when LGS comes in, invariably the examiner is tempted to ask for specific findings in some types of restrictive cardiomyopathy. So you should be mentally prepared for that.
Yes, sir.
Like
Any specific restrictive
specific finding.
cardiomyopathy GLS can target your diagnosis.
Sir, if there is the
Mm.
GLS cherry on top, then it indicates amyloidosis, sir.
It's a great favorite of cardiologists. I mean, it's very important. I agree. I mean, I'm not making fun of this, but it's very important. Good. Anything else?
Any other specific? Like your amyloidosis.
Nothing else? Shovan?
Sarcoidosis.
It's 8:45.
Yeah,
7:45.
it's 8:40.
Yeah.
No,
We have to
I have
wrap
no
up in
problem, but
minutes.
Soumya has
But
to
yes,
decide.
it was very interesting, and I'm also enjoying the discussion. And
Anything else you want to say, Shovan? Your inputs into the entire thing. I think it is very well done, Shovan. I think you have been a very important partner in our learning process. But the only point I want to say, because you are going into a senior residency, finally, examination, I think we must go back and you have, I think you have a very clear idea about the imaging in this thing, but you have to be a little more stronger in your clinical assessment, as Madam was saying. At each step, the examiner should know that is likely to be RCM or a constrictive pericarditis, and never ever start with a DD of constrictive pericarditis. You should say, I am thinking about a biventricular disease which can produce restriction, that something like that, rather than specifically targeting on the constriction. Then they will think that you got a tip or whatever it is. That is very important. And generally, my teachers used to say that in the examination, not for the examination, better to not to say a pericardial knock per se. You should say an early S3. So I think probably it's having put together everything, you think it is a pericardial. That would be a safer way of presenting in the examination also. That's actually the truth in a way. Many times we pick up pericardial knock retrospectively. That is, you do a echo and a CT, and then you okay, that sound was pericardial. Honestly, sometimes.
Yes.
But as Madam was saying, you should definitely differentiate it with the opening snap, because the opening snap also has slightly higher pitch than the usual S3, S4. Okay. Anything else, Soumya? Next, what is the next agenda?
Next agenda is to thank you, sir.
Okay.
Really,
Okay.
sir, you have been very patient and you have taught a lot.
I think
I think
it is a. I must congratulate.
I just want to ask one question,
Yeah.
Dr. Julfikas. So this patient is already like beyond 6 months to 1 year. He's symptomatic. And he has a calcification, definitely, there's no doubt about it.
Yeah.
But still, the ESR and ASO are a little on the higher side. So we are waiting for CMR. We used to get a date for that. We can't get it immediately.
Correct.
Maybe after 5-7 days we'll have.
Correct.
So whether we'll start anti-inflammatory, we'll wait for pericardiotomy, or straight away we'll go for pericardiectomy, we'll wait for
I
CMR.
think
That's the only thing.
38 and 6, they are not very great values. So I think probably we should offer him, I mean, after the CMR, of course, should offer him the surgery. Because it is a late.
X-ray, the X-ray.
Yeah.
Okay.
I mean, but it was really a great case, very interesting one, especially the
I think really educative illustration of it.
And I think I have this opportunity of thanking the worthy faculty of the day, Dr. Zulfikar Ahmed sir
Thank
and
you.
Dr.
Thank you.
Chavi Satpathy, and of course Dr. Jyotsna ma'am, who's always been there to guide our students for their way. Of course, there have been so many participants who must have gained through it, whether it was just a clinical case presentation or discussion about the paradox or the paracardial knock, or the discussions of CMRs and imaging and the ECG findings. It was really very interesting, to the point, and for the benefit of the students to understand the hemodynamics and physiology. I think we fail in our duty if we do not thank Dr. Shovan, who has been a great sport. It's not easy to come and present while
Yeah,
you're doing it
presenting.
here in front of everyone,
I
and it's been great. I think it's a great learning lesson
think
for you, and we are sure that this will go over in years together for giving you that formative touch. And of course, I'm very thankful to my co-coordinators, Dr. Majela and Dr. Soumya, who's been always around and who's kind of coordinated and managed, who is, of course, going to end this by when I stop saying something. But it's been a great day, a great learning session. A big thanks from WINCARS, and we hope to continue to be associated with you even in coming years.
definitely,
Thank
yes.
you so
All of
very
us,
much.
all of us.
Soumya,
Shovan,
on to you, dear.
Shovan,
Thank
before Soumya takes it, I think Shovan, what
Sir,
you should do is you should take this opportunity to do a
sir,
review symposium on either constrictive pericarditis or RCM or both with your madam. That will be very useful to you. At least for you, it will be very useful as a candidate.
yes, sir.
Because
These are
this
very
is
rare cases,
perhaps
right?
this is a
All
rare
like
cases.
overloaded with coronary, like 90% of the things are
Coronaries,
coronary, out of the lab by
yeah,
6 o'clock,
out
7
of the
o'clock.
lab.
You have very little time to
Yeah,
have a clear DM studies these days. So
correct.
these are the
So
cases you have a basis.
you should do a real symposium, etiology, epidemiology. Then you
Yes,
will find out what is the epidemiology. All those things you should do within 1 or 2 months, so that we are strong in both pericardium as well as a restriction.
yes, sir.
Right. Okay. So Soumya,
Thank you.
over to you. Thank you for
Nothing.
anyway.
Thank
Thank you, Soumya, for taking an initiative to invite me. I think it has been a pure pleasure.
Sir,
A little
I'll
bit of
keep on
agony for
inviting you.
yeah.
Yeah. We require actually good clinical cardiologists rather than these.
Teachers, that is, that's how it's this
Right.
e-classes to teach. And I think it's the most important thing to lay those foundations. So Soumya, I request you to kindly conclude the session as we thank our worthy faculty and Dr. Chabi for a great case and learning.
Thank you,
As
everybody.
Shiva ma'am said, thank you everybody for taking so much interest and having so much patience to teach all the postgraduates. Next time I'll show you some CAT tracings of this constrictive pericarditis which we have, so that will be a continuation for the next. And Shovan, absolutely fantastic job. Congratulations.
Yes.
Thank you everybody. Good night.